recording now. Okay, so we're going to talk about hybrid imaging in infection, which is a sort of follow-on from the lecture last year. And this will include both SPECT-CT and PET-CT. And to some degree, I feel that you are the experts in this area, not me. So apologies if you know this already. So I'm going to talk a little bit about SPECT-CT and then PET-CT and where each method may be useful. So the first thing is there a role for fusion imaging in infection and inflammation? And again, it's all very similar to what we said before. We get better localization. We can improve specificity. But with single photon techniques, it does take a lot longer because obviously you need to normally do the whole body or the planar imaging, and then you have to do a SPECT, which takes 15 or 20 minutes. And that may be an issue in terms of camera time. And for some places, just for PET-CT, getting access to machines to do non-cancer can be an issue as well. So we want to know if it's sort of really worth the effort. So there we are, that you can either do SPECT-CT or PET-CT. Are they the same? Are there any differences? That's what we're going to be looking at. So first of all, let's look at the different agents that can be used. Obviously with SPECT-CT, you could just use simple MDP, for example, if you're looking for a spinal osteomyelitis or a sickle osteomyelitis in a long bone, because there probably will be very little else that could cause that in a particular patient. Gallium-67 citrate was popular in the past, but really very few people now use it except in the United States. Then there's white cells labeled with indium or HMPAO, technetium HMPAO. And if you're in Europe, you might have antibodies that you'll use, which are white cell antibodies. For PET-CT, by far the most common agent is just FDG. People have tried labeling white cells with fluorine-18, but they don't seem to work very well. The fluorine-18 seems to be quite toxic to white cells. And then there's gallium-68 citrate, which again is a specialty of South Africa. So we have to go back nearly 15 years to find some of the early work on SPECT-CT and infection. And this is from the Midlands in the UK, a chap called Roach, and he looked at 50 scans. Name was mixture of bone and gallium, shows you how they were using gallium. And they basically showed that compared to SPECT alone, 11 patients had a major change in diagnosis. This is really to do with better localization. And the specificity itself improved by 26%. Here is a gallium study with a SPECT-CT. This is a gallium citrate in a gallbladder abscess by an American publisher called Ho. I think he was working somewhere in the Midwest. And this is in the ACR. And he showed that, for example, this is a patient with cholecystitis. And you can see the gallium uptake around the gallbladder. Now, why SPECT-CT was so useful in the gut is because there's a lot of non-specific gut activity with gallium-67 citrate. So looking at this idea of specificity, a further study was done in 2007, a small number of patients, but they noticed that SPECT-CT yielded what's called added value because of the anatomical localization. And I think the next thing is very important. It improved diagnostic confidence, and the fact that the reporters said that they were much happier with their report. And about half the cases, it did alter the interpretation. Now, which are the agents to use? And that really depends on several factors. the clinical picture. So, for example, in the spine, labeled white cells don't work very well, but most other places they work well. But I think the biggest issue is availability. What is available in your center for this kind of imaging? And to some degree, that has pushed people towards FDG PET, because you don't need to do cell labeling, and it may well be that a pot of FDG arrives once or twice a day, and it's just as easy to use that as to use the FDG for cancer imaging. Cost is also a major issue, because none of these agents are particularly cheap. Even the technician agents aren't that cheap. And imaging characteristics, again, things like gallium and indium have much poorer imaging characteristics. So again, this is a gallium. This is in the patient with an infected renal transplant. This was published in the World Journal of Nuclear Medicine. And this is a patient with a transplanted kidney, which has uptake of gallium. Now, there's no gallium activity in a normal kidney, so this represents a infected transplanted kidney. And if you're very sharp-eyed on the CT scan, you will see there's quite a lot of streaking around the kidney, confirming that there's an active infection or inflammation. What about labeled white cells? Well, again, SPECT-CT works very well with this. And for those of us who have access to labeled white cells, we find them very useful. And particularly, it's a method of choice in abdomen and postoperative cases with SPECT-CT, because we can see any uptake in the bowel and any uptake outside the bowel. And we particularly used it for things like vascular graft infections. And other people, but not myself, have used it in diabetic feet. So this is one of the first papers published from Haifa in Israel. And here they used white cells. These are Indian white cells. And they found that it was 48% more accurate than planar imaging. And you can see why in this image below. This is from the JNM. And A is the planar image. And you can see that there is a focus of abnormal uptake here, which is on the line of where they put in what's called a trouser graft, vascular graft, on the going down the femoral artery. But the question is, well, where is it? So this is the SPECT study when you've got a blob. This is the CT. Now that arrow is pointing to the graft. And when you do the SPECT-CT, you can actually see that the uptake is not in the actual graft, it's in the wound. And that makes a big difference, because a wound infection, you just treat simply, whilst if it was in the graft, it would require a major operation. Now, sometimes they are in the graft, and these are a couple of cases from Cambridge from my patients. And the first one is you can see the metal of the graft here. These aren't vessels, and there's no contrast. This is the vascular graft, and you can see that there's what we call a mycotic aneurysm here, which is an infected aneurysm. And that's quite an acute infection with lots of uptake. This one, however, and this is the second one, the image here, you can see that there are, just after the bifurcation, the trouser graft into the two iliac arteries, you can see the graft with the high contrast metal. And around that is a mass which has low grade but definite uptake of Indian white cells. And this is what happens in patients who have chronic infections and often partially treated by antibiotics. Now, because this is Indian white cells, then this has to be infection. There's nothing really else it can be. And unfortunately for both of these patients, it means they have to have their graft replaced. This is a patient who, again, from us, they had not a actual graft, they had what's called an EVAR, which is placed endoscopically through an artery. And this is to try and sort of do an operation on an aortic aneurysm without actually having to touch the aneurysm. You can see here how big this aneurysm is. And then they got a sort of swinging fever, and they thought it could be an infection in the endovascular graft, and they did asked for a white cell scan, which we did. And when we looked at it, we found this persistent focus in the pelvis, But on the SPECT-CT, in fact, what it was actually in the sigmoid colon. And when we did a sigmoidoscopy, it did in fact confirm this patient had a small nidus of ulcerative colitis that was causing this swinging fever. It wasn't even an infection. So by the use of SPECT-CT, we managed to be much more specific in our answer. So looking at vascular prosthesis, Paola Erba, who is professor in Pisa in Italy, published in European Journal a series of 55 patients looking at technician white cells, looking for grafts, infection, and found that the sensitivity of SPECT-CT was very much better than all the other modalities, including SPECT, ultrasound, or CT, or just trying to guess with clinical criteria. And really importantly, in going back to that first picture I showed you from Haifa in Israel, SPECT-CT reduced the number of false positives so that they were really clear that they were sure that when there was uptake, it was due to an infection. Can SPECT-CT be used in infected joint prosthesis? Well, the answer obviously is yes. Maybe less useful because we can still use things like bone scanning as well, but it may be useful in particular situations, particularly things like chronic inflammation. The other thing is that quite often doctors know, or the surgeons know, whether they've got an infection, they just don't know where it is. And this is an example of a patient that was scanned not to see if they had an infected hip prosthesis, but they wanted to know if the infection was going down the body of the femur, or was it just limited to the head? And you can see here, this is with Indian white cells, fairly aggressive uptake around the head of the prosthesis. But fortunately, it wasn't going down into the actual bone. So the way this was managed was completely different. They were able to drain the pus and give antibiotics, and because it hadn't affected the fact the prosthesis was in the bone, then this patient recovered without need for further operation. So it was really used to map a known infection. And here is a slightly less exciting one, but here we've got a patient who's had a compound fracture, traditional road traffic accident type injury, and they've got a metal bar going down their thigh with screws going in. And again, the Indian white cells show that unfortunately about 4 of those screws have got a chronic infection in, and they all need to come out, and then the wound needs to be drained before they can be refixed. And this is another complex case. So this is a patient who had a traumatic fracture of the ankle, and since then has had all sorts of problems, including a previous infection. You can see they've even fractured the pin that goes into them, and all this is old infection. They just need to know if there was any infection presently, and so we did a SPECT-CT. You can see, unfortunately, there's a big nidus infection posterior to the pin, and there's not a lot more that could be done for this patient other than amputation. What about diabetic feet? Most people or most centers use MR, but there is a value of SPECT-CT. It's a single study done with white cells. We don't normally be able to do the bone scan because they're nearly always abnormal in patients with diabetes and gunky feet or infected feet. And what we really need to know is whether or not the infection is in the bone or in the soft tissue. And that's really what you're doing a SPECT-CT for. And here we have, this one again is provided to me by Professor Paola Erba from Pisa. And here we have a patient. This is a blood flow scan. This is an early scan at 4 hours, and the bottom one is the late scan at 24 hours. And it shows focal uptake of white cells in a the big toe of a patient with diabetes. Now, the problem is that because they have a neurological effect, they don't notice when they do things. But when we did the SPECT-CT, if you look very carefully, where there is focal uptake, there's a very small hyperdense foreign body, and this is a piece of glass that's got into the foot, but the patient hasn't noticed it. And as a consequence, it's then got infected. Now, those of you who are also sharp-eyed would notice that the joint in the big toe is a Charcot's joint, just to confirm it's a diabetic foot. Again, Professor Erber reviewed the different papers that had looked at SPECT-CT in various infections, and had found that, again, the use of SPECT-CT was particularly useful in not only providing a reasonable sensitivity, but also good specificity, and particularly in feet, which are quite difficult to see where you are on just plain imaging. So this is a algorithm that was put together by the EANM Committee for Infection and Inflammation on how you would use hybrid imaging in patients with diabetic feet. It's slightly complex, and I'll let you look at this at your leisure later on. But basically, where there's a doubt from a clinical or X-ray, we would recommend either MR or SPECT-CT, and obviously in nuclear medicine, we would do the nuclear medicine technique. In this particular algorithm, it also includes PET-CT, which has also been used and shown to be very useful. And I'll show you where PET-CT is useful in the next part of the lecture. Now, finally, I'd just like to talk about a case when sometimes you just need to have specificity. So this is a very difficult patient. She has a 4-year-old and she has multiple problems. So she has been deaf since birth. She has lots of behavioral problems, and her parents are find it very difficult to cope with both her and all the medical things. So they wanted to try and see if they could get her to hear, and so they put in these cochlear implants, which work very nicely. But she suddenly started to, about 2 weeks later, to get temperatures, and their fear was that she had infected cochlear implants, which are a nightmare because it could very easily lead on to a brain abscess and death. So they knew we could only do one scan. The problem is, because it's so recent after the operation, a PET-CT would be positive for whatever happened. So we agreed to do a white cell scan, but we only did one SPECT-CT at 24 hours. And this is the relevant picture. And what it shows is that there's nothing in the head at all, but there is in fact 3 areas of focal uptake in the retropharyngeal space. And these are retropharyngeal abscesses, and they are post-operative. So what happened was because she was so difficult to anesthetize, unfortunately, the anesthetist had traumatized the back of her throat, and this had resulted in some abscesses, but they were very simply treated, and the patient was able to go home a couple of days later. If you want to look at some guidelines of when to use label white cells, we developed some guidelines which are available free online through the EANM portal. This gives you some idea of when you should use it and how you should report labeled white cell studies, or if you've got them, antigranulocyte antibodies. So what about single photon versus PET? Well, single photon, we said we have a choice of agent for different types of infection. And I think, to be honest, because most of them depend on white cell labeling, this is better for people who've got immunocompetent immune system. For us, SPECT-CT is standard. You need to do cell labeling, but also quite difficult to do. In terms of scanning, you may need to do it over 2 different time points. But it is very highly specific for infection. FDG PET will find infection or inflammation or any other cause of fever. In some countries, it's still not reimbursed. Obviously, you don't need to do late imaging, but you do need to have the patient reasonably fasted. But it may even be possible to do the scan the same day as a request. If they request in the morning, You can give them a fast and scan them in the afternoon or evening. It will work for both those patients who are immunocompetent or immunodeficient. And I think there's no doubt the sensitivity is better, even though specificity may be an issue. So why does it work? Well, there's some interesting work from about 20 years ago, which was looking at the fact that in infection, the mechanism of uptake seems to be a little different than in cancer. And it's not just related to the fact that you have increased perfusion, but there seems to be an active uptake of FDG. So various people have tried to compare, for example, FDG with other tracers in infection and found that where you have a site of infection, you do get active uptake of the FDG. And it may be related to both hypoxia and the presence of various cytokines. So this is a paper from Japan. And here they have various cytokines in different cell types showing uptake. It's not actually of FDG, it's tritiated FDG. So it's chemically the same, but because it's done with cells, they use a tritium, which is easier to pick up. And you can see that TNF alpha, for example, is a very potent stimulator of uptake in macrophages and fibroblasts, whilst in neutrophils have increased uptake with quite a lot of agents, including some of the interleukins. And when you compare TNF alpha with control cells, you'll see that almost all cell types, except for neutrophils, there is a significant increase in uptake of FDG. So the FDG uptake in infection, in a way, is a bit more specific than it is in cancer. So the imaging protocol, this is as approved by the SNM and the EANM, is to give up to 370 megabecquerels of megabecquerels per kilogram. You might want to use more in large adults. Wait 60 minutes. You can do a limited field of view if it's looking for things like diabetic feet, but most of us will still do a whole body because we'd want to know if there was any infection or problem elsewhere. And again, some people looked at dual time point acquisition, particularly in Pretoria and also in Taiwan. And the evidence seems to swing one way and then the other. So we're not really sure which is the best way. Now, these are our guidelines of what we should, when we think we should be using this. And this is based on a reasonable number of patients. Now, these guidelines are nearly 8 years old now. So probably they need redoing, not by me, but hopefully by somebody else, because there's now a lot more data, which really helps to demonstrate where FDG is useful. So F18's got good physical characteristics, as we know. FDG's got good tracer kinetics. We get the resolution of PET. Image quality is good. We get good anatomical information. And the whole study can be over in 1.5 to 2 hours from injection to report, as long as the patient is correctly prepped. You don't need to do any blood handling, but the uptake is non-specific. You can get uptake in inflammation. Physiological uptake like muscle can be confusing, or around scars, and foreign body reactions. Also, your PET scanner may be busy doing cancer. So these are the indications which were put together, showing that fever of unknown origin was useful also in skeletal infections, vascular graft infections, and certain inflammation. Now, there's something called a Delphi review, which is a kind of meta-analysis that was performed, which I was involved with. And they found that the sensitivity of FDG PET in pyrexia of unknown origin, at least in the Western world, in Europe and North America, is only 52%. However, that was significantly better than any other imaging. And this is because some patients may have a fever without having an infection. So here we have a patient who has all sorts of problems going on. They've got polycystic kidneys, and a month after infection, they've had fevers, and this is 3 areas of uptake. Now, one of those is the renal cyst in this polycystic kidney here, and there's a pelvic abscess in one of the lower external iliac nodes, which we can see very nicely. But this node here, this retrocrural node here, is just a reactive node. So not every site will be uptake, but clearly it does demonstrate the sites of infection. This is a patient with a peritonitis. This patient also was immunocompromised and didn't have any white cells, but you can see very nicely the uptake running along the peritoneum and the skin edema with uptake overlying that. So even though it's not a stunning picture as the previous one, it clearly is positive, and this patient has got uptake in the peritoneum. Sometimes you find some odd ones. This is a patient who had a PUO. They'd had an operation on radiotherapy on the parotid, and it was all thought to be related to that, but in fact, totally unrelated. The patient had a dental abscess, which he didn't complain about, and the doctors didn't check for. So again, some data. So this is some work from the Netherlands, 28 patients, neutropenic following chemotherapy. These days, most patients in Europe and North America immunocompromised aren't immunocompromised because of AIDS. They're immunocompromised because of chemotherapy. Partly this is due to antivirals, which are retrovirals, which are given. So 26 patients had an FDG scan that was positive, 18 in the GI tract, and some of these had injection lines that were positive too, and 7 of them had lungs. Now you might add 18, 9, and 7 and say that's more than 28, and that's because obviously patients can have more than one site of infection, particularly if they're immunocompromised. And they found that FDG was good in both bacterial and fungal disease. Sorry, sometimes it goes a bit slow. So this is a patient from, not from that group, this is a patient from Cambridge. And this patient has had bone marrow transplant and started to have a fever. And we were asked to do an FDG scan to see if they had recurrent disease. And you can see that there's multiple focal uptake in the lung, but this is primarily in lung parenchyma, though there were some nodes. And there's some splenic activation. There's also some gastritis. And we got this node biopsied, and it was a cryptococcus infection. And this is another patient who has had a multiple visceral transplant, so they're very immunocompromised. And again, had a fever, and we scanned their abdomen. There was these multiple focal sites of uptake, and this was a small bowel infection. What about bacterial endocarditis? This is difficult, as you know, to diagnose. Symptoms can be very subtle. If they've got vegetations, then you might get the classical signs of an endocarditis, splinter hemorrhages, etc. But if you don't, or if the patient's been on partial antibiotics, these are rarer. There's a high mortality even in the developed world, and most of these are either strep or staph. There's various criteria. This is the Duke criteria, and the major ones are positive blood cultures, varying heart murmurs, and vegetations on echocardiography. You only need 2 of those. For minor criteria, high persistent fever, known risk factors, repeat pulmonary emboli, these Janeway spots which occur in the hand. These are just small infarcts, like the conjunctival hemorrhages, clubbering, glomerulonephritis, and Osler nodes, that should be not those, which are little inflammatory things in your fingers. And you can have 1 major and 2 minor, but even then it doesn't help because you still need to find the organism. So the European Society of Cardiology and the European Association of Nuclear Medicine tried to put together some joint guidelines. Now, most of the time this is diagnosed using transesophageal echocardiography, but they both groups decided that nuclear medicine imaging, particularly using labeled white cells or PET was a good second line test, but they did note that the FDG uptake may be non-specific. So this is from a paper that was related to this guidelines, and it shows a transesophageal echo with vegetations on the prosthesis, that's the red arrow, and on the CT scan that there was an vascular contrast due to an aortic root abscess. This is often seen when the aortic valve is infected. And then the PET-CT demonstrates that there is uptake in the valve. Now this is quite unusual because this is a native valve and they don't always have uptake, but this is shows uptake, and the patient had an incidental colon cancer, but we're quite used to seeing those. So they came along with this criteria, which is basically if the patient can be proven to have endocarditis by techniques such as echo, then that's fine. But if it's not possible to do that, and it's not always possible to get a good echo picture, or if they don't have all the Duke criteria, then it will be worth doing, particularly PET-CT, and then use that to manage the patient. There are some in patients who've had cardiac devices such as valves and pacemakers and intracardiac defibrillators. They looked at 50 of these patients, and also with patients who expected to have just ordinary infective endocarditis. And they found that they could, in about half these patients, identify an infection. The sensitivity in native valves was less than it was in when there was a device present. This probably is because you get a foreign body reaction around the device as well, but the specificity was very high. Again, a paper from Europe looking at 41 patients with suspected infective endocarditis. 34 had infection, all found with FDG. And they also suggested anybody who has, you're looking for this, it's always worth looking at both the attenuated and non-attenuated corrected imaging. Now, what hasn't been said here was that really since then, most of us have adopted the use of a diet to suppress normal myocardial uptake, in the fact that patients have a low carbohydrate, high protein diet before the scan. So this is a patient of mine who had, you can see that there's the myocardial uptake, and then you can see in this patient with a fever, there is a subtle increased uptake in the aortic valve root. Now, the other thing is, there's always a sign is when the spleen, this is not a lymphoma patient, when the spleen is hotter than the liver, you've got to think of a chronic infection. So how does FDG compare with white cells? So this is Francois Rouzet published this a couple of years back. He looked at 39 patients, which he managed to scan with both techniques before they were treated. And he found the sensitivity of FDG was 93%, but labeled white cells only 64%. But the specificity was a little lower. And the false positives were in patients who had a recent cardiac surgery. And again, he said, look at both the non-attenuated and attenuated corrected image. And this is an image from his paper. And you can see this is the same patient. And you can see here with the FDG PET in the top row, there's very good localization around the prosthetic valve. This is in the mitral valve, but you can't see it in the leukocyte imaging. It's completely negative. So finally, in this section, we're going to talk a little about HIV and TB. And again, you're the experts, not me. And as you know, these things coexist. And this is just a map of Africa showing the tuberculosis incident between 1990 and 2005. And the big difference between the two was the HIV epidemic And when we're looking at HIV and TB, obviously risks of HIV tend to be related to sexual behavior, transmitted by blood and semen, and controlled by antiretroviral drugs. It is possible to contain spread because if the patients don't have high risk activity, then they're unlikely to spread the disease. Whilst TB, HIV increases the susceptibility of the patient to TB. Also, there is no doubt that the incidence is related to poverty because poor people have to live in more crowded housing and often in informal housing. And it can be transmitted not just to the family, but to people who live around, and is a problem particularly in South Africa because of increasing drug resistance. So this paper was published again about a decade ago from the Pretoria group, and they looked at FDG imaging in 4 patient groups: those that HIV positive and TB negative, positive with both, negative for HIV and positive with TB, and negative with both. And they looked at the SCV max in lymph nodes, and the SCV max in patients who were infected with TB was much higher if they also had co-infection with HIV, but it wasn't really possible to differentiate the two. And they did note that there was a pattern disease that involved nodal and extranodal disease. And here is one of their FDG PET scans in the patient. You can see there is, particularly here, there's uptake in the lungs and also in intra-abdominal nodes as well. And this uptake, unfortunately, can be fairly non-specific and may be seen in patients who, for example, HIV with lymphoma. This patient is probably a little easier because they clearly have a diffuse lung uptake. And with that diffuse lung uptake in a patient with HIV, you would think that tuberculosis would be more likely. And therefore, this patient, you're much more likely, despite the fact they've got lots of lymph node disease, you may be much more likely to call as at least some of these could be due to TB. The problem is, of course, is that the lungs might be due to TB and the nodes could still be due to lymphoma in an HIV positive patient. So it's still not possible to say exactly the cause. Here is again a patient with a very little uptake in the center of the chest, for example. It tends to be more peripheral. And again, this is a pattern that is seen in some nodal tuberculosis. However, again, particularly some B-cell lymphomas may have a similar distribution, unlike Hodgkin's, which tends to concentrate in the mediastinum. I suppose the fact that there's so many nodes involved and it's quite symmetrical might make you think that this could be TB, particularly in HIV. Again now, however, of course, it then becomes a differential of sarcoid. So again, from the Pretoria group with Professor Vorster, they compared uptake of FDG in HIV positive patients with TB and known lymphoma. The lung parenchyma seems to be the clue for TB, but lymph node uptake can be identical. But whatever it is, they did note that FDG was very good for monitoring disease activity. And here we have a patient who has pleural uptake of FDG here in the upper left lung, and after several months of anti-TB treatment, this hasn't gone away, but it has improved significantly. So again, this is from the Pretoria group, and you can see that one of the problems with HIV is it also seems to affect the burden of disease. So here is a patient who has Hodgkin's disease, and you can see that HIV negative patients seem to have, though they have mortal nodal disease, those nodes are quite small, whilst when they have HIV, they can have these massive nodes. So, and they seem to have less nodes, but bigger. So it really is quite difficult to sometimes differentiate between the two, but there are certain patterns. Again, you may have better understanding those patterns than I do. So bringing us back up to date, and I showed you, I think, this slide before, is a patient who has COVID, The first case reports came out in April last year, but since then we've been seeing quite more of these. And particularly we've seen this pattern of what's called COVID fire, where you have these multiple lung infiltrates during the active infective phase, and they're very FDG avid. Some very recent work that came out in the last couple of months showed, in fact, that there's no real correlation between this FDG uptake in the acute phase and clinical outcomes. And it seems that some patients are able to clear the virus and the inflammation very easily from their lungs, and other patients have particular problems, and we can't seem to be able to predict that with FDG. Gallium-68 citrate PET, first described by the Bologna group, when particularly looking at bone and joint infection. Did find a few false positives, but generally pretty good sensitivity and specificity. Specificity was a little lower than sensitivity because obviously gallium-68, like gallium-67, can have uptake in particularly in healing bone. So it is a non-specific agent, but in certain criteria it may be more specific. And this is an image from their paper in a patient who has so a couple of patients having fixation, and this is done more than 3 or 4 weeks before. So when you get this intense uptake, it's unlikely to just be post-operative. And then after they did the surgical procedure, they found this intense uptake had disappeared. But if you notice very carefully, there is low-grade uptake of gallium-68 citrate related to all these other surgical implants. So it's not really specific for infection. So you need to look carefully and read the scan carefully. So again, publications from Pretoria looking at gallium-68 citrate in patients with TB and lymphoma. Before we had FDG PET, gallium is how we used to image these diseases. Because it was Pretoria, most of these were HIV positive. And they found that there was slightly more uptake in patients with TB than lymphoma in terms of the SUV max, but it wasn't significant. And the question is, would things like gallium-68 ubiquitin be better? And we'll just have to wait for the research. So just as I'm finishing off, I'm going to have a clinical situation. So here we have a 65-year-old patient who had an aortic valve replacement, and 3 weeks later was pyrexial, which wasn't settling. So what they did is they did an FDG PET study, and this showed uptake in the sternotomy. And so the cardiothoracic surgeons got very excited. Oh, it's a wound infection in the sternum. But I said, wait, don't go too fast, because you can have FDG uptake in normal healing bone. So I convinced them that we should do a white cell SPECT-CT. And when you can see that it's not infected. And so we saved the patient from having a further sternotomy. And in fact, the pyrexia settled spontaneously over the following couple of weeks. So this shows you that FDG is very sensitive and white cells is very specific. So we have increasing use research for use of a SPECT-CT. It has many advantages in specificity and can be used in some improvement in sensitivity. It can be used with gallium, maybe white cells and antibodies, but in reality, most cases we're probably now using FDG PET-CT. So I'm just going to stop there and unmute you.